So hi guys, today we are going to start with lecture 8, which is granulomatous disorders in the series dermatopathology for residents. So when we talk about granulomatous disorders, there are multiple different approaches that you can take. But to keep it very simple, we are going to start off with the palisading granulomas, then talk about the non-necrotic or sarcoidal type of granulomas, and then finally close it with the xanthomatous lesions. So when we talk about the palisading and the necrobiotic granuloma, this first case is an example of that, where you see this 54-year-old female presenting with asymptomatic red-orange plaques on the bilateral shin. So you can see these plaques on the bilateral shins. And when we look at the biopsy here, let's make this straight here. So what we see is even on low power, we see this layers basically. So we see a layer of inflammation, then we see a layer of sclerosis, then we see a layer of inflammation, a layer of sclerosis. So this pattern is known as a cake layer pattern, where you can see the different layers of inflammation and sclerosis in the skin. So when we go high power and try to see what the inflammation is, it's predominantly a lymphohistiocytic infiltrate. So there are lymphocytes, histiocytes, there are admixed giant cells. You can see all the giant cells here. The inflammation also has scattered plasma cells in the infiltrate. And when you look at the sclerotic areas, it is mostly sclerotic dermis. If you do an EVG stain, there might be some loss of elastic fibers there actually. There's usually no vasculitis. So this cake layered pattern that you see here of inflammation that is composed of a lymphohistiocytic composition plus some giant cells, plasma cells associated with the sclerosis, which can even go into the subcutis, is very characteristic of NECROBIOSIS LIPOIDICA. So these usually present as red, yellow, orange, or brown atrophic plaques, often on the shins. They can be associated with diabetes mellitus, but every patient of diabetes is not going to develop NLD. And this pattern of inflammation that we saw here comes under the palisaded granuloma pattern actually. So when we talk about palisaded granulomas, the other diagnosis that you should always consider in the palisaded chapter is one is rheumatoid nodule. So rheumatoid nodule clinically will present as painless skin-colored subcutaneous nodules in patients who have which are usually located on the extensor surfaces. And when you look at a biopsy, very classically what you see is this palisaded granulomas. So palisade, the literal meaning of palisade is like either it could be considered as a necklace, that is a palisade, or the fence that you see around the house basically. So it's like a fence that you see around the house. So this palisade that you see here, this is a palisade that you see here, is around some necrotic area basically. So you can see this, it's almost like forming a ring, a fence around it actually. So that is the reason this is called a palisaded granuloma. This is also forming a fence. So this palisade is usually composed of these lymphocytes and macrophages. And whenever you see this, this is called palisaded granulomas. And when we talk about palisaded granulomas, your list of differential diagnosis includes granuloma annulare, NLD, which we talked about, the necrobiosis lipoidica. The third one is rheumatoid nodule, and the fourth one is necrobiotic xanthogranuloma. So these four will present with these palisades of palisaded granulomas. So when you see this palisaded granuloma, you know that you are dealing with either of these four diagnoses. And then you have to just go into the center of the lesion and see what do I see within the palisade basically. So in rheumatoid nodule, what we see is this completely necrotic area, very eosinophilic necrotic areas within the palisade. So this palisade is composed of macrophages, lymphocytes. In rheumatoid nodule, you might see some plasma cells. Eosinophils are usually absent. And then you see this eosinophilic necrotic fibrinoid changes within the palisade actually. And that is very characteristic of rheumatoid nodule basically. And the rheumatoid nodule tends to usually be in the lower part of the dermis. So you see this palisaded granuloma in the lower part of the dermis. Granuloma annulare usually presents with these annular lesions. that are red-brown, often involving the acral sites. There are multiple different subpatterns, but this is a very classic lesion of GA. And histologically, it comes under the palisaded granuloma. So again, we are going to see that palisaded granuloma here. So in the low power, you can see this palisade forming here. Let's zoom in. So again, you see this collection of macrophages and lymphocytes forming like a palisade or a fence around collagen bundles that don't look as necrotic as we saw in the rheumatoid nodule. So here you can see that the collagen bundles are altered compared to normal collagen on the outside, but they still maintain their outline. So this reaction pattern is known as necrobiosis. So it's not necrotic, it is not normal, somewhere in between necrosis and normal. So this is necrobiosis. So you see this palisade of granuloma around necrobiotic collagen. And if you do a mucin stain, you're going to see increased mucin within the palisade. So you won't see increased mucin outside of the palisade, but you're going to see increased mucin within the palisade, and that is very characteristic of granuloma annulare. Granuloma annulare is a very common cutaneous manifestation that you're going to see, and histologically it can present with either that palisaded granuloma that you saw, but there are other variants that you should be aware of. One is known as interstitial granuloma annulare, where you can see there's a lot of inflammation. So it's called a busy dermis. So this is very busy. There is a lot of action happening throughout the dermis. Vaguely, there is some palisade formation, and if you do mucin, you're going to see pools of mucin scattered throughout these infiltrates. So it won't be throughout, but pools of mucin scattered throughout the dermis. And characteristically, I remember in my training with Dr. Rapini, he used to say perivascular lymphocytes and interstitial macrophages. So if you remember that, that is a very nice feature to remember for granuloma annulare. Perivascular lymphocytes that you see here, and then the interstitial macrophages. So if you see that scattered throughout the dermis, and then if you do a mucin stain and you see pools of mucin or increased mucin forming focal areas throughout the dermis, that is very characteristic of granuloma annulare interstitial type. Another variant that you should be aware of is deep GA, because this could be misdiagnosed as a rheumatoid nodule. So because again, here in the deeper part of the lesion, you see this palisades of granuloma that are forming around necrobiotic collagen. Here the clinico-pathological correlation is very important, because this tends to occur in children, so somewhere between 10-20 years old. And then you see this deep lesion, and this is usually on the extremities. And then when you go high power, you see this collection of macrophages forming around palisades around necrobiotic collagen. And often you are going to see a lot of eosinophils, not a lot, but you'll see admixed eosinophils within the infiltrate. So eosinophils are commonly seen in all variants of granuloma annulare. So if you see eosinophils, that also favors granuloma annulare. So this variant of GA that is more common in young children is called deep granuloma annulare, where you see the palisade in the deeper part of the dermis, composed of macrophages, lymphocytes, and plus minus eosinophils around necrobiotic collagen. Again, if you do the mucin, it's going to be increased within the palisade. So moving on to the last differential diagnosis in the palisaded granulomas is necrobiotic xanthogranuloma. These are usually associated with monoclonal IgG kappa gammopathy, and they present with this red, brown, yellow plaques, often periorbitally, that you see here. So as the name suggests, necrobiotic xanthogranuloma, so there's going to be a lot of necrosis. There are going to be xanthomatous cells, and there are going to be granulomatous cells. So you can see these large areas of necrosis that you see here that are surrounded by these palisaded granulomas. So you can see these large areas of necrosis throughout the dermis. So that is the necrobiotic xanthogranuloma, because if you go high power, you're going to see xanthomatous cells, which are lipid-laden macrophages. So you can see a lot of xanthomatous cells within the infiltrate. You can see the xanthomatous cells. And then if you look around, you're always going to see two-tone giant cells actually. So the two-tone giant cells are very characteristically seen in necrobiotic xanthogranuloma. Another characteristic feature that has been described is the presence of these cholesterol clefts within the necrotic area. So you can see all these cholesterol clefts within the necrotic area. So the giant cells, which could be either two-tone giant cells or multinucleated giant cells, cholesterol clefts, large areas of necrosis that are surrounded by this palisade of lymphocytes and macrophages. And you might see some plasma cells, but you don't have to sit and waste your time. But otherwise, it should be an easy diagnosis when you see necrotic areas surrounded by palisades, admixed two-tone giant cells, and then scattered cholesterol clefts throughout the lesion. So that is all the features for necrobiotic xanthogranuloma. Moving on, the next type of granuloma is the non-necrotic. So these were all the palisading and the necrobiotic. When we move on to the non-necrotic type of granulomas, the classic thing that we normally talk about is sarcoidosis. So 38-year-old female presents with red purple bumps on the nose. So you can see that here, which is very classic for sarcoidosis. So when we talk about sarcoidosis, we talk about naked granulomas. So you can see all these granulomas throughout the skin. These are composed of mostly macrophages. And the word naked comes because granulomas tend to have normally associated lymphocytes, which we don't see here. So it's only composed of just macrophages. And that gives it the name naked granuloma. So they don't have the cover of lymphocytes that they normally granulomas would have. So this collection of macrophages, some giant cells, you might see some asteroid bodies. And once you see this, you still have to do your stains to make sure it is not some sort of an infection process. So you do the AFP, the PAS, FIGHT, and once everything is ruled out, then sarcoidosis is a diagnosis of exclusion. So these are known as sarcoidal granulomatosis, and then compatible with the clinical impression of sarcoid once you have ruled out all the infectious processes. A sarcoidal granulomas is supposed to, clinically, this is a great mimicker, so it can look like a lot of different things. In Lofgren syndrome, you have erythema nodosum plus hydroadenopathy plus uveitis plus migratory polyarthritis. And there are multiple syndromes that you need to know of that are associated with sarcoid. One is Diarrhea-Rossi disease and the other is Herford syndrome. So just remember these for your board exams. Sarcoidal type of granulomas can also sometimes be seen in cutaneous tuberculosis, especially, and then leprosy, especially in the tuberculoid leprosy. And then you also have to remember zirconium and beryllium, which are foreign material used in certain industries. Like zirconium is used in the fluorescent bulb industry, and beryllium, I think, is used in the beryllium is used in the fluorescent bulb industry, and zirconium is used in some sort of drugs admixed in antidepressants. So these might also show a sarcoidal type of granulomatous reaction pattern. When we look at a lesion here, so this again has a lot of granulomas. You can see this granulomas that look a little bit sarcoidal, but when you go high power and you look at this granuloma, there are a lot of admixed lymphocytes. But within these macrophages, there's a lot of material here actually. So you can see a lot of material within this macrophages. So if you did a fight stain, this would actually light up. So this is a lepromatous leprosy where you see this globi within the macrophages. So you can see a lot of these bacilli within the macrophages. All of they are all like filled up with this bacilli. Another feature they normally talk about is the Gren zone basically. So the Gren zone is the area of uninvolved epidermis right below the dermal epidermal junction. So most infections tend to abut the dermal epidermal junction. When there is uninvolved papillary dermis, then it is called a Gren zone. Gren zone is also talked about in B-cell lymphomas, and also the other condition I think is granuloma faciale. So granuloma faciale, you're going to read about Gren zone in lepromatous leprosy and then type B lymphomas. Foreign body granulomas can also be seen in ruptured epidermoids, which is a very common thing that we will see in dermatopathology. And then we have to remember gout and sometimes a tattoo reaction. So ruptured cyst, the diagnosis sometimes is difficult because we don't see the cyst lining, but here you can see the cyst lining, so it's very easy. The cyst lining is here and then it is associated with the granulomatous reaction pattern, which is composed of a large number of giant cells, lymphocytes, macrophages. So foreign body reaction to a ruptured epidermoid cyst. Sometimes we don't see the ruptured epidermoid cyst, the lining. So what you have to look for is the presence of this admixed keratin flakes. So if you see this admixed keratin flakes within the giant cells and within the inflammation, that is a hint that this is associated with a ruptured epidermoid cyst. Gout tends to present with this tender, warm joint lesions around the joints, and they can be yellow-white colored nodules that you see here, the yellow-white, often on the finger toes and the ears. Histologically, the diagnosis is easy where you see this deposition of pale pink homogeneous material, often trying to form like crystals that you see here. But if you want to see the crystals, it has to be fixed in alcohol, not in formalin. The thing that you want to look for is the foreign body reaction that you see around the pale eosinophilic material basically. So you want to see this reaction that you see here composed of macrophages and giant cells and lymphocytes. You want to see this to make the diagnosis of gout. So this, you can see this crystalloid pale feathery material that you see here surrounded by this inflammation that is composed of macrophages. And that is very classic for gout. And if you just see the pale material and you don't see the foreign body reaction, like in this biopsy here, you can still see some material here, but outside of the material, we don't see the foreign body reaction. This is very characteristic of triamcinolone. So a patient that has been injected with Kinolog. So this is all triamcinolone injection, which you can see that this is like again pale pink material that you see within the dermis forming these big nodules, but normally they don't tend to have a foreign body reaction. So if you see the foreign body reaction, more likely to be gout. If not, then more likely to be triamcinolone. So another place where you might see the sarcoidal or the foreign body reaction is with tattoo. And it is important to rule out underlying sarcoid because tattoos can produce sarcoidal reaction, but the patient might have underlying sarcoid and then the overlying tattoo. So here you can see that this is a very sarcoidal type of granulomatous reaction pattern, but then scattered throughout the lesion is this dark pigment that you see here that is either free or some within the macrophages, some within the macrophages, some lying free. So this is a tattoo with a sarcoidal type granulomatous reaction pattern. So it could be related to the underlying sarcoid, and sometimes it would be just like a foreign body reaction related to the tattoo. Another place where foreign body reaction is important is this paraphenoma or sclerosing lipogranuloma. If you see this biopsy where you see all these style, you could misdiagnose this as a lipoma. So you see almost like a lipoma-like reaction. But what is different is that you can see that these spaces that look like lipocytes are there is a big variation in the size and the shape. So some are small, big, some are very small. So whenever you see this variation in the size and the shape of the lipocyte looking spaces, and then they are associated with a large amount of inflammation, chronic type, lymphocytes, macrophages. So the patient has injected, so this is a very common reaction pattern to something that has been injected into the skin. Maybe it is silica, maybe it is something else. And then you see this variation in the size and the shape of these clear areas that tells you that these are not lipocytes, but something that has been injected here basically. So if you see this associated with a lot of sclerosis and associated with chronic inflammation, you have to think of either paraphenoma or sclerosing lipogranuloma. Moving on to the last type of granulomas that we will see is the xanthomatous. So xanthoma cells are these clear macrophages that contain lipid. So lipid-laden macrophages that are also known as foam cells actually. So you can see this large cells that are called foam cells. So when you see that, that is a xanthomatous reaction pattern. So very characteristically seen around the eyelid, 42-year-old male presents with asymptomatic yellow bump near his eye that you can see here. Histologically, it is composed of these foam cells actually. So you can see all these large collection of nodules of these foam cells or macrophages that have this lipid within them and a very small nucleus. So this is a xanthomatous reaction pattern around the eyelid. This is known as a xanthelasma. So xanthelasma presents with this yellow-orange periorbital plaques, and histologically you see this collection of foam cells within the dermis. Other places where you're going to see a lot of xanthomatous cells, one is eruptive xanthoma. This clinically presents with numerous sudden onset of yellow-orange papules, more commonly on the extensor surface. The important thing to remember clinically is these are usually associated with some sort of a lipid disorder. The eruptive ones is associated with severe chylomicronemia and hypertriglyceridemia. So these patients tend to have lipid abnormalities. So if you have this diagnosis, the patient should definitely get a lipid profile. So eruptive xanthomas contain again a lot of xanthomatous cells, which might depend on the stage at which the biopsy is done. So you can see the xanthomatous cells, but these are usually not only xanthomatous cells. There is associated other cells like lymphocytes, plasma cells, eosinophils. But characteristically, xanthomatous eruptive xanthomas tend to show this lace-like lipid material that is extracellular. So you can see this lace-like extracellular lipid foam material between the xanthomatous cells, and that is very characteristic of an eruptive xanthoma. There might be some fibrosis, but if you see this, then you can easily make the diagnosis of eruptive xanthoma. The other ones are the tuberous and the tendinous xanthomas. Tendinous xanthomas present have painless subcutaneous nodules associated with the tendon. Again, they are associated with hypercholesterolemia and elevated low-density lipoproteins. Histologically, there is not much to say because these are again a collection of xanthomatous cells. You might see some admixed lymphocytes and other kinds of cells like eosinophils, but characteristically they tend to be just xanthomatous cells. And then you have to do a clinical pathological correlation to make the diagnosis of a tuberous or a tendinous xanthoma based on the location. And then also you all make sure that the patient then gets a lipid profile done actually. So you again see this collection of macrophages with some admixed lymphocytes. The tuberous, so that was the tuberous and the tendinous xanthomas. The plain xanthomas usually present with yellow papules or patches. They can be in the intertriginous areas. They can be distributed throughout the body. So when they are distributed, or then you have to think of hyperlipoproteinemia from primary metabolic abnormalities, and also some sort of lymphoproliferative disorders when the patient has plain xanthomas. If they occur on the palmar area, they are nearly pathognomic for familial dysbeta lipoproteinemia. Again, the histologically, there's not much difference here. What you're going to again see is this xanthomatous lesion that is composed of these foam-laden xanthomatous cells that you see scattered throughout the dermis. So these are the xanthomatous cells that you see here. There might be some admixed two-tone type of giant cells that you see here, one here and the other here, but nothing very particularly different from the other kind of xanthomas that we saw basically. One interesting variant that you can easily make a diagnosis on low power is verruciform xanthoma. So verruciform xanthoma, it's easy to make the diagnosis on low power because this characteristically presents with this very eosinophilic, reddish looking, almost like a fire stratum corneum. So when you see this is low power, like it's very easy to think of verruciform xanthoma. And once you start thinking of it, you just need to go high power, and then you look at the dermal papillae, and within the dermal papillae, you're going to see this collection of foam cells. And when you see this two in combination, then the diagnosis is verruciform xanthoma. These tend to present either in the oral cavity or the genitalium, but characteristically, this should give it away that you're dealing with verruciform xanthoma. And now coming to the last two diagnoses in the chapter, one is xanthogranuloma, or last three diagnoses. So xanthogranuloma is another common lesion that we see in young kids. Smooth pink yellow bump. Histologically, it can look very scary because they are like usually filled with a lot of different kinds of cells, so they can look very atypical. Sometimes there might be more fibrosis depending on when the biopsy is taken, if it is taken after a very long time. But they tend to have this collection of a large number of different kinds of cells. So you see the xanthomatous cells, you see plasma cells, eosinophils, lymphocytes. Characteristically, we also see a large number of two-tone giant cells. So this two-tone giant cell, where you see this wreath of nuclei surrounded by this very clear cytoplasm. So that is a very characteristic two-tone giant cell, and you can see them scattered throughout a juvenile xanthogranuloma. So if this occurs in an older patient, then we just call it xanthogranuloma. If it occurs in a very young kid, then it is called a juvenile xanthogranuloma, and it is composed of this mixture of all types of cells with this two-tone giant cells. Can look scary, but given if you do the clinico-pathological correlation, then it's an easy diagnosis to come to. Other diagnosis, one is ROSAI-DORFMAN, that can also present with this xanthomatous lesion cells. These usually the cutaneous lesions are seen in 10% of cases, and they present with this solitary yellow tan papules and sometimes with the paniculitis. Histologically, what we see is again these xanthomatous macrophages that you see here forming a big nodule. So you go high power, it is composed of these large number of histiocytes that have, so these large histiocytes that have this very big nucleus and a very prominent nucleoli. So that is a very, the collection of these cells associated with lymphocytes, neutrophils, plasma cells is very, very characteristic. The other feature that you see is this imperiopoliosis. So you see this lymphocytes within the cytoplasm of the macrophage. So there's one here, and you could, if they are not very easily visible, you could do the S100 and the CD68. These large histiocytes, they tend to stain with both the stains S100 and CD68, and then characteristically you will see this not staining within the cell basically. So it's then easy to find the imperiopoliosis. One cell that is always present is the plasma cell. So if you see this histiocytic proliferation and then you look around and you see the plasma cells, ROSAI-DORFMAN should always come to your mind that maybe this is ROSAI-DORFMAN. Then you do the S100, CD68, you look for this imperiopoliosis, and then you can make the diagnosis of ROSAI-DORFMAN disease. And then the last diagnosis in this section is reticulohistiocytoma, that can again be confused with the other xanthomatous disorders. So these are usually skin colored or red brown formed papules, often on the head and neck. When they are multiple, it is called multicentric reticulohistiocytoma, but usually they present as single lesions in adult men. Characteristically, when you look at these lesions, they are again composed of these cells that look a little bit xanthomatous. So you go high power, you see this very characteristic macrophage here that has this very ground glass like cytoplasm. So this ground like cytoplasm is a very characteristic feature that is always seen in a reticulohistiocytoma. Hopefully you can take a picture and put this in your brain, that if I see this kind of cytoplasm and I see a large collection of these cells and there's an admixture of eosinophils, lymphocytes, plasma cells in the background, then my diagnosis is going to be reticulohistiocytoma. But this cytoplasm color is very, very characteristic. This ground glass sandpaper like cytoplasm that you see here is very, very characteristic of these large macrophages that you see here with a very big nucleus, often prominent nucleoli. Look at the cytoplasm here. Put a picture in your, take a picture, put it in your brain, so that the next time you see these slides, that will always come to your mind. So if you think about it, then you can make the diagnosis. What the mind doesn't, like if your mind doesn't think about it, you will never make the diagnosis. So I think that was the last diagnosis. So if you want to see additional slides, if you want to see additional images for each of this diagnosis, you just go to publications.pathpresenter.net. Go to this free online resource, Dermatopathology for Residents, and you'll see multiple digital slides and multiple clinical images for each entity. Thank you. Have a nice day.